Welcome to Virtual Face-to-Face with Dr. Bruce Jarrell. I'm Alex Lukowski, Executive Director of Media Relations. Consider the words of Eileen McStay, an ER nurse at Mount Sinai Hospital in New York City back in March. I have worked the last 4 days and I have cried every day. I haven't had a hug in 7 days, not for my kids, not for my parents, and it kills me. Now, granted, the rate of infection in many states like Maryland has been slowing, but in the most populous states, California, Texas, and Florida, it's on the rise again. And the trauma suffered by thousands of clinicians all over the country has already taken its toll. They've been overworked, isolated, poorly nourished, sleep deprived, and underappreciated. They live with the fear of contracting the disease or bringing it home to loved ones. And many have experienced a sense of helplessness, unable to provide adequate care or comfort to COVID-19 patients when they've needed it most. A study published in the journal General Hospital Psychiatry found New York clinicians showed high levels of stress, anxiety, and depression, especially among those with the greatest amount of patient interaction. More than half had high levels of acute stress and experienced insomnia. Nearly half screened positive for depressive symptoms, and about a third had anxiety. The study also points up a concern that prolonged acute stress may lead to post-traumatic stress syndrome. Worse still is the prospect of increasing deaths of despair, deaths due to drug or alcohol overdose, or suicide brought on by the pressures of COVID-19. Probably the most widely publicized case is that of Dr. Lorna Breen, Emergency Department Medical Director at New York Presbyterian Allen Hospital, who died by suicide in late April. So what is being done and what can be done to provide the care that our care providers so clearly need? Joining Dr. Jarrell today are Dr. Patricia Attman, Clinical Assistant Professor, Department of Psychiatry at the University of Maryland School of Medicine, and Dr. Delia Chiaramonte, Medical Director of Integrative and Palliative Medicine and Co-Chair of the Physician Wellness Committee at the Greater Baltimore Medical Center. She's also maintained ties with our School of Medicine as a volunteer assistant professor and is adjunct faculty with the School of Pharmacy. Welcome to you both.
Thank you.
Thank you.
Before we go on, I need to let everyone know that this program is being recorded and will be posted on our COVID-19 website, umaryland.edu/coronavirus. In a little while, you, the audience, will have a chance to ask your questions. Just look for the chat button. It looks like a speech bubble down at the bottom of your screen or in the upper right-hand corner if you're using a cell phone. Write your question there, and when the time comes, we'll call on you. So listen for your name and speak up. Now, with all that out of the way, here's our host, UMB President, Dr. Bruce Jarrell.
Thank you, Alex, for that introduction. Dr. Attman and Dr. Chiaramonte, thank you very much for being on with us today. This is an important topic. It's a topic that many of us have experienced before, and most of us know little about in terms of how to deal with it. So I'm looking forward to your insights as to how we might be better informed to take care of ourselves and others. So let me start out with a question for Dr. Attman. Could you talk a little bit about what burnout means for students, how you define it, how you know it's happening, and how you deal with that? Dr. Attman.
Yes, thank you. This is such an important topic, and this has been a problem even before COVID-19. We as physicians, as med students, we tend to suffer more than the general population in terms of symptoms of depression and stress. And physicians generally have developed symptoms of burnout as they go through training, but it can start in medical school. Burnout is defined as a triad of exhaustion, depersonalization, and a sense of lost self-efficacy. So physically and emotionally exhausted. They develop a sense of distance from their work, almost a cynicism, and then they sort of lose their sense of value as a contributing member of the healthcare community. And the symptom of criticism is probably the most important in terms of how it affects their emotional state and leads to more serious mental illness.
Right, and how would a student self-recognize these kinds of things, or a physician as well, but either of us?
Yes. So, you know, one thing about medical students and physicians is it's very hard to self-assess because we train in an environment of stoicism, and we're sort of the considered to be the experts in many areas, and we don't get sick. We kind of tell ourselves that, and the institutions kind of expect that in some ways. So we do tend to be more of stoics. We don't ask for help. We don't recognize symptoms. Usually other people will. And the problem, because physicians don't look for help, they don't even visit their primary care doctors frequent enough to be screened for symptoms. We do lose a lot of opportunity to find the physicians who do need help. And there's also a stigma. So physicians are very nervous about actually going to get help, because what does it mean about their profession, and what does it say about them, and how will it impact their career? And if they do get help, they usually go out of town. They don't want their colleagues to know. They don't want to be seen going into, a psychiatry clinic or a therapist office. So there are a lot of barriers to getting help, and even if they were to recognize it, it's very difficult to get the care that they need.
Yeah, I remember when we rearranged the counseling offices in the university, one of the important issues was to have them in a location that was not identified as a clinical care or that type of care facility, so that you could be like everybody else and walk in a door and not be noticed as seeking help. So I guess that was a good decision back then, huh?
That was, and thank you so much for that. We really appreciate all your work with us.
Great. Dr. Chiamonte, again, thank you for being here. I know you're on the front lines. I know you're dealing with healthcare workers every day. You're dealing with COVID, all of those types of things at GVMC. Could you tell us a little bit about what you're seeing and how you're recognizing sort of what's going on with each individual?
Sure. As part of the palliative care team, we do provide direct care to COVID patients. So while I talk to other physicians, I also am experiencing it myself. And there are some things that are particularly different about this time in caring for COVID patients and even caring for other patients in the era of COVID. And for COVID patients specifically, one of the things that is particularly difficult is that they often come into the hospital not that sick. So sometimes when someone brings a loved one into the ER and they're ultimately going to die, everybody kind of knows that on the way to the ER. And now that's really not the case. People walk in on their own. Maybe they got a positive test in the community and then got a little short of breath, and someone said, oh, you should probably go to the hospital. Family members are not allowed to accompany them into the emergency room. And so they walk in, get admitted, and everybody is expecting that they will come home. And sometimes these people we've seen have been in their 40s or 50s, so it's not just grandma or great grandma. And then they have abrupt declines and sometimes die. And that is not only, of course, traumatic for the family, but it's traumatic for the healthcare providers too, because often, not always, but often the people that die in a hospital, nobody was that surprised that that's how it went when they walked in the door. But now with COVID patients, they look well and then they crash and die. And that is tremendously difficult for the healthcare providers when you see that over and over and over and over again. So that's one piece that's so hard. The other piece that's so hard is that families aren't allowed to be there to be part of the decline and the anticipatory grief when a patient is really declining. So not only are families more agitated and upset because they feel the need to be there, but they can't be there, but also it even brings on a little bit of moral injury in the healthcare provider, because we know if your loved one is dying, you should be there. We certainly understand why you can't be there, but there's a part of our kind of heart and soul that feels like, gosh, it's not the same on the iPad. You know, we talk to the family on the phone, we tell them this bad news, we say, well, would you like a video visit? But we know that watching your loved one die by video is not the same as being at their bedside. And so healthcare providers face compassion fatigue when they see these traumatic events over and over. They face moral injury when they see things that just feel wrong, even though they understand why they have to happen. And they can have some secondary traumatization when they see how distressed the patients and families are And over, they get a little sort of PTSD themselves from watching so much trauma and stress and sadness with other people. So it's a different time.
What do you tell your family in situations like that? What kinds of things have worked and not worked, at least in your experience?
For the families?
Yes.
Yeah, there are a couple things that really make a difference. On the palliative care team, we made up, sounds silly because it's a form, but we made up a form that is basically get to know my loved one. And so we tell families on the telephone when we're talking to them, we have this thing and I want to hear all these things about him so I can put this up in the room. So every doctor and nurse and tech and dietary and everybody that goes in that room knows about your loved one. So people tell us things like he loves Dungeons and Dragons, or he's such a sports fan, he loves the Yankees, or, you know, pasta was his favorite food. So things that wouldn't show up in the medical record, but are really part of what rounds the person out as a human being. And so I think just getting the information from the family member is itself an intervention because they're happy someone asked, and it makes them feel like we really care.
Yes.
And then, of course, we tell them that. We say, we know he's your dad. We know he's a human being. We know you should be here, and we're so sorry you can't be. So we will try to step in for you. And, you know, we promise that someone will be with him when he passes, which we have almost always, through nurses or somebody on the team, have been able to do that. We sometimes certainly will have video visits. We've had some that were hours long, basically a kind of death vigil. The family wanted that. They wanted to be there by video when the person passed. We've allowed that to happen. We ask them sometimes, are there certain prayers that you would say if you were here? We're happy to say them. Do you want to record a message to me on the phone while we're talking and I'll play it for him? So sort of anything we can do. And we had, once we had someone on the team hold hands with the patient while the family, we brought the video as close as possible and we held the hand. So the family said, like, we're holding you. So we tried to make it be as close to the family being there in person as possible. So it makes a difference some, but it's not the same. Of course, it's not the same. And partly we just acknowledge for the family that we hurt for you. We know this is not the same and we're so sorry. This is what's happening for your family.
Yeah, I'm sitting here hearing you say all of that, and I just get immensely sad to hear how difficult that kind of situation must be for anybody in the world. You've got a person who you expected to be with you for another 5 or 10 or 50 years, and they're suddenly going to be gone, and I can't even be next to them. It's got to be a very difficult situation.
It's so difficult. And the other part that is almost incomprehensible, but has happened multiple times, is sometimes multiple people in the family get this at the same time. And we've had families who have lost both parents within the span of a couple weeks. So imagine going through it once and then going through it again with your remaining parent. And so the level of suffering is just, it's incomprehensible.
Yeah, there's not words to get it even. So, well, what for the both of you, Dr. Atman and Dr. Chiamonte, what do we do to prepare our clinicians or our students for this kind of situation? We know what they're walking into. There may be another wave coming. What can we do better to be prepared for the emotional roller coaster of all of this? Either of you.
Dr. Atman, you want to go first and then I'll go?
Okay, so sure. So the first thing really is to not only be prepared for a COVID crisis, but for any emotional crisis. And anytime a doctor walks into an ER, hospital, or in your office, you want to be stable emotionally and strong and resilient yourself. So the key is really taking care of yourself. So no matter what you walk into, you're ready and stable. So and most important, just as you brought up, Dr. Jarrell, recognize in yourself when you need help. So many times, as I said earlier, the doctors don't want to ask for help, and we need to make it easy for doctors to ask for help. We need to take away the stigma. We need to create ways that they could get support without feeling like they're going to be checking into a psychiatrist's office. They want to be able to get support that is acceptable, that they feel is acceptable and works for them. So having a variety of tools available and easy to access and acceptable, and many times it's peer support too. So knowing that you're not alone. I mean, doctors tend to live isolation a lot because they're working in solo practices, but being able to connect with other people and experience hear what they're experiencing and know that you're not alone, and partner maybe with someone. There have been some programs where doctors have partnered with other doctors during the COVID crisis, checking in, making sure that you're okay. So there's a variety of things that we can do to bolster the emotional resilience of physicians and even med students and all grad students. By the time they get to grad school, they're already being confronted with so much stress. So teaching resilience, stress management, healthy lifestyles. There are a variety of things we can do, but we need to develop a program that makes it easy for people to walk into and get the tools that they need, and not create barriers and fear of stigma and resistance.
Well, of course, there were always those group therapy sessions. I always think of AA. I think of other kinds of therapy. Have those been used in this situation?
I don't know of things exactly like that, but there definitely have been, as Dr. Atman mentioned, peer support, which is very helpful. And also sometimes the peer support is one-on-one, but sometimes the peer support is in groups and things like resilience rounds, where you get everyone together in a protected environment so you can share what's really happening and share what was difficult. And we're actually just starting something like that soon, hopefully at GBMC. I like to think of it that there's really three pieces to the resilience of a physician and anybody else, not just physicians. And the first is their intrinsic stuff, like how optimistic or pessimistic are they? How anxious or depressed are they as a human being? There's that piece, which we can address in some ways, which we can talk about. The second piece is their behaviors. So are they sleeping? Are they exercising? Are they meditating? Are they overusing alcohol or shopping or gambling? So behavior. So there's sort of who you are as a human being before you even got here. There's what you're doing. And then there's the environment in which you're doing it, which is more from the organizational point of view. And so all of those three things need to be addressed, in my opinion. And part of the environmental one, so that's external to the physician, has includes something that Dr. Atman mentioned, which is culture. So this culture that exists in medicine where we're fine, we got it, we're fine. I'm just gonna, let me go take a walk, I'll walk it off, I'll be fine. And if we create this sort of wellness just as help, like when you're really struggling, come get help, you will lose most of the physicians. So the goal long-term, I think, would be actually to change the culture and create a culture where we admit as a group, all of us, that this is hard work. And in order to really be present and empathetic and emotionally available to your patients, in order to be that person, you have to take care of your own wellness. So just like in order to be in the military, you have to keep working out because it's important to be physically fit. We need to be emotionally fit in order to do this really difficult work. And the more we can make that just part of the culture for medicine, I think the more we will prevent burnout, as opposed to letting everybody tough it out and finding people when they're on the verge of quitting medicine or committing suicide and then giving them, quote, help. So my vision is that someday it's not help, it's just what we do. It's just what we do to increase our own optimism, decrease our own anxiety. And there are lots of things that do that we have healthy behaviors, and that we work in organizations where there's a culture of course, you're taking care of your wellness because that's what physicians do.
Yes. Of course, we've been hit hard enough in this country. New York City was hit particularly hard. Italy, Spain, some other places have been hit particularly hard as well. I wonder how their physicians and healthcare providers and nurses have been dealing with this. Have you been hearing any stories or lessons to learn about that?
So there are Facebook groups that are physician only addressing COVID, and they're international. And we're all feeling the same way. And those that were in places that were much harder hit than here are feeling it much more extensively than we are here. But it does appear to be that people posting from all different countries are saying the same sorts of things about they don't call it this, but explaining moral injury and compassion fatigue and traumatization, and I can't do it anymore and I don't care anymore. I'm losing it. I can't find myself anymore. And those are all signs of walking towards burnout.
Gotcha. I want to encourage those of you who are on, welcome for being here. We welcome your questions. Please type them into the chat button, which Alex pointed to you, because you got two experts sitting here. Let's make sure we take advantage of everything they have to tell us about that. So the Facebook groups sound really interesting to me. Now, I'm not a Facebook guy, so I have to learn how to do that. But I guess social media is playing a big role, not just Facebook, of course, all of these different things. Have either of you dealt with this as a positive or a negative?
I find it to be a positive myself, but it is sort of interesting, I have to say, to live through history as we are here, because physicians will from other countries post, look at this brand new study that was just done in our country that hasn't hit the news. And so sometimes those things become more widely recognized and some they don't. So there's a little bit of, oh, in Italy they said this and that turned out not to be true, but what about this? But that turned out not to be true. So it is a new experience to see it unfolding rather than saying, well, let me educate myself on all of the knowledge that already exists on this topic. But having personal support and knowing you're not alone and feeling, concerns about PPE, that's something that is widely shared, that concerns for personal safety are another thing that's different about this particular event rather than the standard things that most of us have experienced in caring for patients. And changes in the home, many people are not sharing a bed with their partner anymore if they feel like their partner is at particularly high risk. And so there's changes that are different that we haven't experienced before.
Yeah. Well, I remember seeing a tweet from an Italian physician that someone had sent me, and the physician was saying just how severe conditions were and people in the hallways and all that stuff. And it sounded so extreme. And we're sitting there saying, well, this is just a tweet. What's the validity of this? How do I know this is valid? Turned out to be highly valid. Turned out that I'm glad I read it because it certainly was a forecast for what we had to prepare for. Right. So I saw it as a positive, but it would have been nice to have a little bit of validity to it to know it was for real. Dr. Ottman, in terms of the students and mental illness, particularly in this current environment. So they're pulled away from classes, they're pulled away from the usual environment. What's the interplay between that dynamic and any bringing out mental illness, joining with mental illness? How do you view those two, or are they just separate things?
No, it's an excellent question. So I would say a large percentage of people have adapted well. In fact, some have symptoms have been relieved because there's the stress of having to show up early, drive into the city, they're at home, they're sleeping in, they're being cooked dinner by family. So it's in some ways it has been helpful. In other ways it's been hard because many things have been put on hold. So medical students have had to wait and go into the clinic rotations. Other students have delayed their applications, so their exams, everything has been delayed, and then there's this sense of uncertainty. What will become of my applications to my residency program, and how do I move forward? There's some people who have difficulty with online learning. So we do have people who are struggling with that because then you are responsible to show up, to be on the computer, whereas physically there's more interaction. So we have a mixture of things. If there's anything, the anxiety seems to be a little stronger, related to just not knowing what the future of their ongoing academics will be.
Right. So we don't have much in terms of dealing with these issues in the medical school curriculum, do we? Or the nursing school curriculum? I don't know how much you know about the other professional schools. I wonder what we should be thinking about in that, or is that all learned on the job?
I think it's not learned on the job because none of us really learned how to take care of ourselves in medical school. I think it is just a crucial part of medical school curriculum. And that is part of changing culture. I think it's probably easier to change it for medical students and then have them bring the culture into the medicine of the future than to try to change all of us older attendings who are set in our ways, although we should try. But to change the medical students who I think are open to this idea of wellness and self-care and just make it be part of the curriculum, it's part of being a doctor. And there are all kinds of things that we can teach them. We can teach them mindfulness, which means focusing your attention in the moment you're living, not the bad thing that happened last week or the thing you're afraid of tomorrow. We can teach them positive reframing, which is trying to look at a difficult situation that's complex, but pull out the parts that are positive, which the more you do it can become habitual and change the way you think. We can teach them the value of gratitude rituals, which are evidence supported for decreasing anxiety and depression and increasing optimism. We can teach them the importance of exercise in managing depression. We can teach them about sleep. There's a whole host of things that we can teach them that they can use for themselves to build up their resistance so that when they end up in difficult situations, they're not already depleted and trying to do hard stuff from a place of depletion, but they're more filled up. And when they're more filled up, they're more resilient and able to cope with difficulty.
Right. I want to encourage the listeners to give us questions. We obviously want to serve your curiosity on this important topic. It's a broad area, and so again, I want to encourage you. In terms of self-help, so I'm on an airplane and I need help. You think people will come to my aid during this era, or are they just emotionally so afraid to get involved because they might get something from me? They're not protected. So what's the dynamics of that kind of situation, either in a plane or on the street or wherever it might be?
It's an interesting question, and I've heard physicians talk about it. I think we're more likely to carry an N95 with us than we were before, just in case. I do think most physicians would still help somebody because it's who we are. But there's no question that there's a complicated interplay of helping you but not hurting myself. But if I have gloves and an N95, I can help you.
What do you think of that, Dr. Attman?
Oh, well, I'm a psychiatrist, so I usually don't get up on the plane.
No, wait a minute. If I'm sick, I can depend on a psychiatrist. I'll bet you there's a few.
I could do a blood pressure check.
Who would say that?
She would help us. I know she would.
Yeah, I think I would hope so. We have a wellness center at UMB, do we not? Are either of you involved with that at all?
So for quite a lot of years, 10 years, I was actually the part of the Center for Integrative Medicine and the Director of Education, and for part of that time, the Associate Director, and ran an integrative medicine elective. So we've taught quite a few University of Maryland students about wellness and self-care through the elective. And some of those things happened at the Wellness Center. Some of them happened in the community. Some of them happened at the Center for Integrative Medicine. But the thing that I think is important is that that's just an elective, so that's not everybody. I think in the ideal world, it would be everybody.
Okay. Dr. Attman, anything to add on that?
So, well, one thing when Delia was on staff full-time at the university, we worked hard to advance the curriculum to include self-help and emotional wellness for all grad students and especially med students. And it just there was no time in the schedule, which is kind of sad because, it's very critical. If you're not functioning, you can't be, an effective physician, dentist, etc. Other programs, universities have started, and I sent a link to you of a Mount Sinai Center for Stress, Resilience, and Personal Growth. That came out of COVID. So Mount Sinai has a program. Stanford Medicine has a wellness program for doctors, and we have employee assistance. We have kind of bits and pieces, but it would be really nice to have a huge, just general center for well-being where people can come in and learn techniques to manage stress. I mean, we have we have, I believe our student counseling center is excellent, and we provide so many opportunities for students to come in, and compared to the national statistics of other colleges and graduate students, we're actually doing quite well in terms of the students wanting to come and get help. So I think we're doing great. And then the move to the new physical location is wonderful. So that's great for the students, but I'd like to see a similar thing for the physicians. And one other thing I've been wanting to mention is that there's so much pressure on physicians to perform. There's the deficiency quota flags and quotas and reimbursements, and electronic medical records they take up a lot of time. And you know, a person who's already hard on themselves and overachievers and perfectionists, and you know, they forget about the 99 people that they saved, and they agonize over the one item that they were, quote, deficient. So I would love to see an opportunity to grade different departments according to their wellness. So, you know, is this a happy place to work? Is the team, you know, feeling healthy and happy and cohesive? What is the doctor satisfaction rate, and along with the patient satisfaction rate? So maybe some measures that reinforce a culture of wellness and taking care of oneself.
Yeah, we ask a lot about patient satisfaction, don't we? But we don't ask a lot about physician satisfaction, I dare say, or nurse satisfaction.
What we measure, we reward, right? I think that's a great idea, Dr. Ackman.
It is. So I want to remind those on the chat to please get your questions forward. Alex, you have a few questions I see. Why don't you ask one?
Well, I'm going to ask one for Michelle Peralta, who you may know, because she says she's currently breastfeeding her 4-month-old who was born during COVID, so she doesn't dare speak. And she told me I could tell you that. She says, what are things that one can do to support? Well, let me start from the beginning. She says, by the way, she's the senior assistant director of the Wellness Hub, the health promotions office for the students at UMB. So I'm curious, from your perspective, what topics should we be addressing in the upcoming year for our students, for their well-being? Currently, as I mentioned, she can't speak, but you know, students will have a lot of questions, and what do you have for them?
I'll start, and then I'm sure Dr. Ackman has suggestions too. I think one of the things that is undertaught is self-compassion, because physicians and healthcare providers and students on their way to those professions are very hard on themselves, and they will focus, as Dr. Ackman mentioned before, on the one thing that didn't go well, even though there were 9 things that did go well. And so when a family is upset, or a patient dies, or it doesn't work out the way everybody had hoped, the healthcare provider and students too can take that on themselves, and that's part of what increases their stress and leads them towards the path of burnout. So the idea of self-compassion, it has a couple components, including understanding that things happen. So reminding yourself that things happen, that they don't always go perfectly, that everybody has difficult situations or makes mistakes, that we can choose where we put our attention. So we could choose to pick the part where the family was grateful that we were there, rather than the part where the patient didn't recover in the way that we had hoped. And we can do some intentional wellness behaviors to help turn down our stress response and our sympathetic tone. So meditating, or going for a walk, or taking 10 deep breaths, or listening to guided imagery. So putting it in the framework of self-compassion, I think, is really important. We're taught in medicine often it's all about the patient, which is good and important, but it's not only all about the patient. It's also really about us and our own well-being. And the more compassionate we are to ourselves, the more we fill up our own emotional cup, physical and spiritual cup, so that we're not depleted, the better care we're able to give to the patient. So I think the thing I really never heard about in medical school is self-compassion, and I think it's a really important topic.
Dr. Ackman, anything to add to that?
Yeah, I would agree 100%. The other thing I have to say, whenever I work with students, the relief that they express when they realize that it's okay, that this is not, the symptoms that they're having is a result of a variety of stressors or vulnerabilities, that we can talk about emotional wellness and not illness, that there is a way to move through this, giving them hope that it's not something that they're burdened with, or that it's a fault or a flaw, to have feelings. It's okay, and that we can work through this. I think there's, because of the stigma, and mental illness tends to have such bad connotations when you ask for help, but if we look at it, it's just as if you have an injury to a muscle. We just need to support the injury as you walk forward and strengthen the resilience and begin to move in a more healthy way.
Right. Alex, you have another one?
Yes, you may have already answered most of Charles Shalee's question. It's also about students, but I'm going to let him decide whether he got a full answer. Charles, are you there? Charles, are you there?
Yep, there you go. Now it's unmuted.
There you go.
Yeah, there we go. Yeah, so you could maybe look at this a couple different ways, but how are students who have been able to help with the COVID-19 patients handling this environment emotionally, especially if a longtime clinician that they're maybe looking up to for advice may not have all those answers?
I'll give you that one, Patty, because we're not actually allowing students into GBMC right now.
Yeah,
with any.
So, and I haven't worked with the students who've actually been on the floors with the COVID patients, because I don't think that they are allowed to interact with COVID patients. I guess if your question is like, what do I say about the profession of medicine in the middle of this acute crisis? I guess I some clarification there, but some people have asked, well, does this experience discourage one from going into medicine? Would knowing that this level of distress can occur, would that discourage one? But students, I think, well, as we mentioned, people are generally resilient if given the right tools. And we as doctors, we go into the field because we love science and we love using science to heal people. And yes, COVID came out of nowhere. It didn't follow science that we knew of at the time, and we weren't helping people. So it was traumatic on all levels. But I do believe that in the end, we'll come through this, and we'll really have a feeling of control. We know how to treat this. We know what this is. And then we can go on doing what we love doing, which is healing people and making life better for many.
Yes, so Charles, maybe I could chime in a little bit here. We have not allowed our students, any of our students, to be directly involved in individuals who have been identified as being positive for COVID. We took that stance back in March, and it was primarily based upon the idea that we couldn't protect them in ways that we thought was relevant. So we didn't have enough protective equipment. We didn't have testing to know who was and who was not positive. That's still, both of those are still on short supply. We didn't know enough about the disease to know who was at risk, how serious the illness was. Could we get a student or other people in serious trouble? I think the answer today is, yeah, we could have, couldn't we have? So we've been very reserved on that. Starting in July or even late June, so pretty soon, we are allowing certain student experiences to occur in the clinical arena, but again, we're excluding the care of known COVID positive individuals. The hospital still worries daily about having the right number of sterile gowns or face masks or that kinds of thing. So they've not been in that environment. I could have turned the question around, and maybe I will turn it around to our two panelists to say, wait a minute, I went into medicine. I can't protect myself from these things. I need to be taking care of these patients. So what do you think the effect of not allowing our students to care for these patients, if any effect, might have? Is there a lack of commitment, or are we being wrong in thinking this way? What's your reaction to that?
I was thinking that when you were talking about this question, actually, that, gosh, I wonder if they feel sidelined.
Yes.
Here they were going into medicine. It's this huge societal crisis, and everyone's saying, go in the other room. This isn't for you.
Right.
I have been teaching or working alongside residents, which are not that far from medical students, and they're doing, first of all, a fantastic job. They're completely committed. I do think students could contribute, but the one thing that I have had the opportunity multiple times to bring up with residents, which I think will also be relevant for students when they start working with COVID patients, if that happens, is that just because the patient died doesn't mean you didn't do important work. So we didn't give this person COVID. It's not our fault that they died. But if we were there with the family, we were there with the patient, we were bringing our compassionate presence to the very best of our ability, we were walking alongside the family on this really difficult journey, that's really meaningful. That's not nothing. That itself is a clinical intervention. And I think I've had more opportunity to share that, not just with residents, even with some other attendings and nurses and other people on the team, about how important that piece of the whole care puzzle is. It's not just about cure. It's a lot about walking with the family on this journey that they're on.
Yeah, something not to forget, particularly in these days.
Truly.
Any other comments, Dr. Atman? Any other comments? No? Okay, Alex, let's move to our next question.
Well, a lot of questions about how family and friends can support care workers. We have on our Facebook Live feed, Mega Delawit Yarefu, who asks, you're a non-healthcare worker. What can you do to help someone facing clinician burnout? And in our audience is Laura Cathcart. Laura, if you're there, do you want to add to that question?
Sure. I just want to thank all of you, first of all. This has been a really powerful presentation to listen to and to hear about everything that's been going on in the hospital. I know I've been working, and a lot of us at UMB have been working alongside our colleagues at the University of Maryland Medical Center, but not in the hospital, and so there's a distinct difference. And so it's very powerful to hear about potentially what they've been going through. And so it's very clearly very stressful for them. And so the question I have is how can we best support them right now in this clearly stressful time? And especially those of us who are not clinicians and who maybe can't exactly relate to what they're going through?
That is such a great question. And I don't know if my answer will surprise you, but what I really think is just let them talk about it. Because I have a few select people who are used to hearing my stories now, who I can rely on, who have basically said, it's okay, dump it on me. But I don't want to do that to a lot of people because everyone is scared, right? This is not just happening to me. This is happening in the community. Everyone is scared. And so to hear about younger people who are in the hospital, who are dying, that traumatizes the person I'm speaking to. So I often feel like I have to be careful. I can't share really what my stories are that would be helpful for me to get out because I don't want people to be afraid to talk to me and I don't want to traumatize all my friends. So I think if you have a healthcare person in your circle and you know that they're dealing with these things and you tell them, you know what, if scary, hard, sad things happen and you feel the need to talk about it, you can talk about it with me. I can take it. That would be a beautiful gift.
Thank you.
Yeah, we haven't even touched on the non-clinical care individuals. There are all the paramedical people. There's the people taking people to the morgue. We heard many of those stories in New York City, and that's got to be a powerful emotional roller coaster as well.
The people who clean the rooms are in just as much danger as we are, but they don't get the salary that we do, and I think they don't get the glory, and they should. But I have noticed that within the healthcare community, everybody realizes that. I had I'll just share with you a poignant moment with someone who cleans near where I work. And earlier on, I just stopped and said, "How are you holding up?" And she got tears in her eyes and I got tears in my eyes. And it was just a moment where we realized our job titles are different, but we're really exactly in the same situation right now. And in a way, it's normalizing all of us, like we're all suffering in the same way.
Alex, got some more questions?
Yes, we have Rose Alvallero, who is the Clinical Services Director at the University of Maryland Safe Center. Rose, are you there with your question?
Yes. Thank you so much. This is very helpful. I am a clinician and I am doing direct services with our clients. One of the things that I believe is important is this issue of empowering our clinicians and our medical professionals to ask for help, to engage in this self-care. And, you know, as we went into working remotely, that was one of my struggles, you know, how to deal with vicarious trauma, because now is the service that we provide as clinicians is more intense because we are able to see more clients because these barriers of, you know, distance and transportation has been removed, so more people are engaging, and because of the crisis that we're having at the level of, you know, public health, we have seen a tremendous increase of clients coming for behavioral health services. And so my question is, how do we deal with, you know, vicarious trauma? Many times, you know, as a clinician, I found myself with intrusive thoughts about the narratives that we have, you know, that clients share with us that are difficult sometimes to hear and to manage.
So just as a note for our two panelists, Rosa is at the Safe Center, which is a human trafficking control and prevention program that we stood up 5 or 6 years ago. So I think that's probably part of your question, isn't it, Rosa?
Yes.
So Dr. Atman, Dr. Chair.
And Rosa, thank you for what you're doing. Is it that you're meeting more people remotely on a Zoom or WebEx?
Yes, there is, you know, increased demand on services, and because, you know, people are able to connect easily to their phone or video, it's one after another, and you know, how to manage many times not having that opportunity to process the experiences for as a clinician.
Yeah, so, you know, I find, so because we're working out of our home and we have the video available to us 24/7, and we can schedule people, and people can just pick up their phone and call us. So the barriers, as you mentioned, are lessened for people to come in. And so now so we do have what's called Zoom fatigue. So a lot of clinicians are more fatigued. It's very hard to assess people on using a video conferencing technique because there's so many nonverbal cues that we pick up in a room. So it's more exhausting to work with people through the internet, and then you're getting more so how do you take care of yourself? And that's exactly what we're saying. The healer. The clinician needs to really take time to heal themselves in order to be available. So if you could share the burden, if there are more people who can pick up the number of callers, then have a support for yourself. And I miss being in the office where I could just stop in someone's office, say, look, I really need your advice here. I miss talking to people that way. And it's hard when you're just alone at home in front of a computer and it doesn't even feel human. It's very important that you reach out to others, seek support. If you're, I don't know what type of clinician you are, but many of the professional societies now have links to professional support groups. Speak to therapists, people in the field that you feel comfortable with. there is secondary trauma for sure. And the field that you're working in has got to be heartbreaking. Thank you for doing the work.
And I think I agree with all of that. I think there are some specific things that I use myself and I recommend. One of them sounds sort of funny, but it's helpful. Sometimes it feels like when you're taking on others' trauma that it gets stuck in the body, and just shaking. Sometimes I walk down the hallway, people make fun of me. If it's been something really bad happened, just taking a few minutes to shake it off. Exercise, aerobic exercise, helps decrease the sympathetic tone, decrease the physiologic stress response. So walking up and down the stairs 5 times, really feeling tight, like it's stuck. Shaking and exercise can help with that. Other techniques, when we're feeling a little calmer, relaxation breathing can help. Listening to a guided imagery, including an app. So Headspace, for example, is one app that they're giving away free to healthcare providers right now. Having 10 minutes a day where you're listening to a guided imagery through a wellness app. There's emotional freedom techniques, sometimes called tapping or EFT, that can release some stuck emotions. If you have trauma that's reactivated, which is definitely happening for providers and for patients, EMDR, eye movement desensitization and reprocessing, is that right, Dr.? That can be helpful. So there's a lot of specific techniques, and I think different ones work for different people. So one of the things that I think is helpful is recognizing first, we have to be filling up our own emotional, physical, and spiritual cup. What are the tools that I like, 3, 4, 5 things, and putting them into our routine all the time. So not waiting till we feel burned out and then going, oh, what was that place I could go for help again? But rather starting today, putting into our cup so we're more resilient. So that when these difficult things come up, where we have more resources. And then when it's a really bad day, shaking, walking up and down the stairs, doing your breathing, putting on a relaxation CD. If you've learned tapping, do some of your tapping, talk to a friend, talk to a therapist if you have one. So I think knowing what is in our toolbox and when to pull out which tool is really helpful, and is something that ideally we would be helping students and residents and attendings learn how to do. Teachable.
I think we need to build that into Zoom and WebEx. I think that might be part of every meeting, don't you think?
Sure.
Yes.
It would certainly help me. Sit here an awful long time every day. So, Alex, do you have time for one more question, maybe? Or...
I do. I have a couple of anonymous questions. This is a two-parter. The audience member writes, first, many med students and residents are actually told not to show emotions when a patient dies or when you have to share bad news. Don't tear up, don't cry with the family. Do you think this situation will change those old attitudes? And the second is a comment. She says, I've heard from a few doctors that one of the ways hospitals are dealing with the tremendous deficit is to have fewer docs in the ER, fewer hospitalists, et cetera. This puts enormous additional stress on them.
Yeah. The first one, don't show emotion. I flat out disagree with that, I have to say. I think showing emotion is appropriate as long as it's not about you, the clinician.
I can hear somebody typing. I'm not sure if our audience may be having a hard time hearing you, Delia, but go ahead.
So what I'm saying is I disagree. I think that showing emotion in small amounts, as long as it is not the focus on to us, the clinician, is perfectly appropriate. So tearing up in a really difficult time, and when we could touch people, giving hugs to someone would be appropriate. Now, if you're sobbing because it's reactivated your own trauma and you're trying to make it about you, that's obviously inappropriate, and you should go somewhere and get help for that. But staying stoic in a really emotional situation, I think, is distancing, and it's actually part of healing presence to be there with the family where they are. And if they're really sad, it's okay for you to share some of that too. But that does mean you have to go and have your wellness behaviors to take care of yourself, because if you keep taking on other people's sad, then that's how people end up towards burnout and being depleted.
Yeah, it's really easy to lose that during internship. And I think a lot of people lose that in internship, and you have to gain it back.
You do. And there's actually evidence, not surprising, I think, that burnout leads to decreased empathy in medical students and other clinicians.
Yes.
So that's part of why burned out doctors are not as good at their work. They're not as empathetic. They make more mistakes. They're more likely to get sued. So it's, even a benefit to the healthcare system to try not to have burned out doctors.
Yes. Alex?
All right, we have another anonymous one. This person writes, we sometimes tell clinicians to focus on the altruistic reasons that they got into this line of work and to put others first. But don't we need to step back and tell healthcare workers to take care of themselves first, or else they won't be there to help anybody in the future?
Yes.
Right. Yeah,
Well, that was an easy one.
This program's all about, right?
Totally agree.
Yeah. It's like being on the airplane. You got to give yourself the oxygen. Otherwise, you can't help anyone around.
Right. You can't pour from an empty cup. So if your cup is empty, you can't be as helpful to your patient. So that's what I mean by changing the culture. It's, I think, the responsibility of a good clinician to take care of their own wellness, fill up their cups so they're filled with empathy and they can bring this healing and compassionate presence to their patients. If they allow themselves to get depleted, they're not as good at their job, and that shouldn't be okay, in my opinion.
And we got to make it okay for doctors to ask for help. We got to make it okay for people to want to help each other. So, and the culture, the stoicism and the, this emboldened sense of I can manage on my own, that needs to change.
So we're just about out of time. First of all, I want to thank the two of you for your wonderful participation in this. I've learned a lot in these, and the tough old surgeon figures out that maybe it isn't so good to be a tough old surgeon. Maybe it's good to learn about emotion and things like that. So I really appreciate these kinds of things. They're useful to me, and obviously from the questions you can tell there's a lot of people paying attention. So I want to thank you very much for being on this with us. It was a joy, and I will look forward to another one later on, because we may need you back here soon to give therapy to all of us.
We're here for you.
Happy to be there. Thank you for having us.
Thank you very, very much, and we'll be in touch.
Bye-bye.
Thank you.